Welcome, everyone. Thanks for joining us tonight. I apologize, I was a little tardy. I'm really excited tonight. We have with us Dr. James Stephen, who's going to be out at the Colorado Chiari Institute. I'm really excited to hear what's going on over there. I feel like it's been forever since we've been talking. We've been even gone to Colorado. I think it's been a minute. So usually what I do, I have the presenter kind of introduce themselves, speak a little bit about why they are interested in Chiari and treating Chiari patients or any related disorders really. And then you're going to do a brief presentation, and then I'll pop away for a bit and I'll come back in when we do the Q&A session. So I'm going to go away and I'll just have you introduce yourself, talk a little bit about why you're interested in this, and you can get started.
Perfect. Thank you very much. All right. Thanks, everybody. I'm James Stephen, neurosurgeon, and I'm affiliated with the Colorado Chiari Institute, just outside of Denver, Colorado. A little bit about myself. My background is in mechanical engineering, biomedical engineering, some biofluidics, and trained in neurosurgery and moved out to Colorado. I trained at Penn in Philadelphia, so spent 12 years out on the East Coast, and been here for a little bit over 3 years. I had a great opportunity to work with Dr. John Oro, who was basically the founder of the Colorado Chiari Institute here, who dedicated his life to treating Chiari patients, and sort of very well known in the community. And I had this great opportunity coming out here to study under him, to work with him, and eventually he retired after a long, productive career, and I've ushered his practice along. Given that my interest is in engineering and fluidics, Chiari malformation was a good fit for me. I like sort of the mechanical aspects of it. I like the decision making that goes into who gets surgery, what's the best surgery. I like the fact that it plays such a big impact in patients' lives, the diagnosis, and you're able to shepherd them through that diagnosis and weigh the pros and cons of different approaches and think about all the different other medical and non-medical things going on in order to make good decisions with them. It's super rewarding to see them get better either with surgery or without surgery, and to help provide them some answers and spend time with them, get to know them. So that's a little bit about me. We'll talk today about sort of the initial evaluation, like what happens a little bit before and then during the initial visit for patients that come to see us, and what are some of the important things to consider before making decisions about surgery or other treatment options. So we'll get started. Like I said, James Stephen, the medical director, primary surgeon at the Colorado Chiari Institute. We're located in Aurora, Colorado, which is just east of Denver, right along the front range of the Rocky Mountains. Got some nice Rocky Mountain photos here. And like I said, the practice here was built by Dr. John Oro. It's a tertiary referral center, meaning people come from not only Colorado, but all around the United States. And that's a real honor for us here. Here's a map that shows the United States and the states that are green. It's not a political map. The states that are green are states where we've treated patients. And so, you know, it's still a few states where we haven't, but majority of the states we have, and people come all over. And that's largely due to the reputation of the clinic, and the reputation of the clinic is largely due to Dr. John Oro. So, and because of that reputation, and because people are really traveling oftentimes a long way, we take it very seriously how much thought and time and effort we put into these evaluations to really try and get to the bottom of what's going on. And that'll be the focus of the talk today. So some of our goals, my goals as a surgeon, as a physician, and our goals as a clinic overall is to identify and select patients with suspected Chiari-1 malformation and or syringomyelia. Part of that involves some pre-screening. Then we evaluate patients in consultation, and that is a variety of things go into that. Patients meet with Kimberly Sexton, our nurse practitioner, have an initial visit, undergo a wellness visit where we're looking at some of the health and social factors going on in their life. What are the barriers to getting better? What are some things that they could try? Really sort of like an educational session that can really set people up for success, because it's not just one thing that we focus on. We try and focus on the whole patient and really optimize all the different tools that exist to get them feeling better. The other part of the evaluation is an hour-long visit with me where we go through all the things we'll talk about today. And then ultimately, at the end of the visit, what we're hoping to do is provide diagnostic and treatment recommendations. And sometimes that is, we know for sure what's going on, and this is what we're going to recommend based on your individual presentation and all the evidence that we have. Sometimes it's, you've got a great start on things, but we need to just gather a little bit more information. We got to check a couple things to make sure there isn't something else going on. I always think more information is better, especially if that information is going to make subtle changes in the way that we do things. And oftentimes patients will follow up with us at a certain period of time after doing certain tests. Sometimes if people have really done everything and everything is more straightforward, sometimes it's a decision that doesn't require a follow-up, such as scheduling a surgery or getting plugged in with a specialist that is more apt to treating what we think is going on. And then whatever route we go down, however things end up in one visit or multiple visits, ultimately the goal is really to maximize the quality of life of the patients. And that's sort of the focus of the talk. Sometimes surgeons do surgery, and we want to help people. And the way that we help people is generally by doing surgery. But we have to be careful that we're doing surgery on the right people, and the people that have the best chance of getting better. And if somebody comes and gets evaluated and gets treated and their quality of life is better and they get on with all the things they like to do and they don't need surgery, that's a big win for the patient, for me, for everybody. And so I ask patients to kind of bear with me as we navigate this together. So Chiari malformation and the symptoms that go along with it come with a broad differential diagnosis. And that's just a medical term for what are the things that could be going on that could cause symptoms that are similar to the symptoms that the patient is having. Sometimes this is what could be going on that makes a radiographic picture look like an underlying Chiari-1 malformation. But when you look a little bit more closely, it could be related to another either related or primary disorder, which makes things look like it's a Chiari. And these things can be easy to miss, and sometimes when they're missed, that leads to patients having worsening quality of life and worsening outcome. Chiari malformation is tough because the symptoms vary. Different people get different symptoms. The symptoms can be what people in the medical profession describe as vague, meaning non-specific, meaning that they could be caused by a variety of different things. And not every symptom reads the textbook of what disease it's supposed to go along with, and vice versa. And so we have to kind of think about all these different things and to rule them out to make sure that we're not coming down on the wrong diagnosis. So a few things I've listed here on the slide, and these would be things that I would evaluate for when you come and see me, would be idiopathic intracranial hypertension, what used to be called pseudotumor cerebri, or IIH, CSF hypotension, which is spontaneous intracranial hypotension. Both can go along with Chiari-1 malformation or can cause the MRI to look similar to Chiari malformation, but the underlying problem isn't a Chiari. It's one of these diagnoses. Craniocervical instability, or CCI. This is oftentimes related to hypermobility syndromes and connective tissue disorders such as Ehlers-Danlos. Sometimes it can be related to prior trauma. And it's a spectrum, and it's an area of medicine that isn't super well understood, but it's very important to evaluate people for this diagnosis, because sometimes if you think it's just a straightforward Chiari and you go ahead and do surgery on these folks, they can actually get worse after surgery. And so it's very important to listen and look for this, and we're very cognizant of it in our patient population. Cervicogenic headache, this is sort of the classic neck pain that radiates up into the head from whiplash or from just degenerative disease, poor posture. And you can get concomitant Chiari and cervicogenic headache, but if the issue is more coming from the neck, it doesn't make sense to operate on the brain. Occipital neuralgia is another pain syndrome where the headaches are very similar to Chiari, both in quality and in the location. And that's another disease that we screen for. Basilar migraines or other type of migraines, atypical migraines, also can be pretty similar to Chiari. And there is a myriad of other headache, either primary or secondary syndromes that we look for. Autoimmune diseases such as MS or some of the more poorly understood autoimmune diseases can present a lot of the same symptoms as Chiari. Fibromyalgia, chronic fatigue syndrome, again, these are diagnoses that medicine doesn't have a very firm grasp on what exactly the cause is. It's more of a constellation of symptoms, and there can be overlap in these patient populations. So kind of a lot of things, this is just a short list, but a lot of things to keep in mind when we're seeing people. And a lot of what we do is aimed at getting to the bottom of this. So before you come and see us, we do a few things to select patients and make sure we're not wasting anyone's time coming all the way here, either from Denver or from outside of Colorado. One of those is an MRI of the brain with and without contrast. And that's going to help us radiographically look for a Chiari or look for some other underlying diagnosis. We also want to get an MRI of the cervical spine, which is the neck, which is going to show the presence of a syrinx, which is going to show presence of some of the other pathologies that can occur in the neck. And that could be, it's also going to show us a slightly different look at the junction between the neck and the skull base. So all patients come in with those images. We ask to get some laboratory values, hemoglobin A1C to check for uncontrolled diabetes, vitamin D to sort of check for overall health, and nutrition to see how much nutritional help people need. And then CRP, which is sort of a non-specific marker of inflammation, which can correspond to smoking tobacco, underlying autoimmune disease, underlying rheumatological disease. It can be a red flag if it's elevated, that maybe look a little bit more closely at what else could be going on, maybe get a rheumatologist involved. And just by having all of those, it provides us with just a little bit more information. The other thing is we want to get notes, and we want to make sure that you've seen a primary care provider, just like a family doc or internal medicine doc, or and we also encourage everyone to see a neurologist. And neurologists are sort of do a lot of the medical management and oftentimes diagnosis of different types of headaches. And we want to make sure that somebody that isn't a surgeon that's just looking at things a little bit differently has seen you, and has hopefully tried to treat things with medication or done certain testing. Um, some of his patients can be a little bit frustrated by their experience with neurology or by having to go to see another neurologist. But a lot of the recommendations and things that we make are aimed at helping patients really try everything they can before they make a decision about surgery. And if you have migraine headaches but haven't tried any migraine medication, it could be that maybe the migraines are playing a bigger effect on your quality of life than the Chiari, and fixing the migraines may get you to where you want to be. And while it's frustrating, the trial and error with medications, it's ultimately easier than undergoing a big surgery. And it's just a little bit of a way to have multiple people looking in on you and giving you different perspectives, a surgical perspective, a medical perspective, and to go from there. For folks that have had surgery before on their Chiari malformation or on their syrinx, it's a slightly different set of criteria that we ask people to get before their first visit, just so we have a little bit more information. So all of the previous page would apply, but oftentimes we want to get a three-dimensional CT scan of the head just to get a picture of what the bony decompression looked like with the previous surgery. Are there any skull base anomalies? How big was the bony removal? Things like that. Is there a plate there? Can really sort of help us from a surgical perspective. Another thing that's helpful for that is the operative note, which generally contains information about what the surgeon saw and what they did, and it provides us, in many ways, if the note is complete, a good picture of what was going on with the other surgery. A cine MRI is a special MRI that looks at blood flow, or sorry, looks at blood flow, but also the cerebral spinal fluid flow. And that can be helpful to look for the development of adhesions or blockages of the spinal fluid, which may not show up on a regular MRI scan. But if the flow is blocked on a cine, it can provide us with information which may suggest that there's a recurrent problem after the surgery. And again, the notes from the surgeon and the other docs that have been treating you to just get up to speed on what else has been going on. So what is a patient evaluation? The patient evaluation starts with a history, which is just a conversation with the patient about their symptoms. And the history is really important because we're not in the business of treating MRI scans and looking at lab values. You really have to listen, see what people's symptoms are, what makes things worse, what makes things better, how did things start, how things evolved, what worked, what didn't work. And oftentimes just the history alone, and you got to take some time to do this, is enough to kind of really point us in the direction of, okay, that seems more like it's falling into this diagnostic bucket versus this diagnostic bucket. So that's really important because MRI alone doesn't tell the story. Physical exam. This is important because certain diagnoses are going to be associated with certain findings on neurologic exam or physical exam, areas of tenderness, areas of pain with certain movements. So this is another key ingredient in getting the full picture of what's going on. We are surgeons. Surgeons rely heavily on imaging. The diagnosis of Chiari is really an imaging diagnosis as far as the criteria, and we do review imaging. And sometimes we'll review imaging and based on that imaging want to get a slightly different image to get to the bottom of something that comes up on the history and physical that now that we've met and spoken, we have a better idea of what else may be going on. Lastly, we want to go through the neuralgia notes. In addition to your impressions from what's been going on with neurology and what things have helped and didn't help, as well as any other doctors that you may have seen that have been working to get to the bottom of what's going on, either successfully or unsuccessfully. just so that we, again, have a complete picture. So this slide talks about the most common symptoms that patients present with Chiari-1 malformation. Headaches, dizziness, difficulty sleeping, weakness or numbness in one of the arms or legs, pain in the neck, fatigue, being nauseous, nausea, vomiting, shortness of breath, difficulty with vision, ringing in the ears, difficulty swallowing. Other things that are quite common would be difficulty concentrating, difficulty with language, feeling like you're not yourself, and the list goes on. And this constellation of symptoms isn't unique to only Chiari. Some people have the very classic symptoms of Chiari, and it's more straightforward. But as I said before, sometimes these things don't read the textbook about how they're supposed to behave, and you can have one thing that is a Chiari, but it's behaving more like something else, or vice versa. And because these symptoms are so common from just other things that are going on, it's really important to consider all the other options. So we'll talk a little bit in more detail about each of the components of the evaluation. So as I said before, many Chiari-1 symptoms overlap with other diagnoses. And that's challenging to parse through, but it's very important to try and get a really good sense of that. Just to elaborate a little bit, on classic Chiari-1 headaches, they're suboccipital in origin, meaning they sort of start back here at the base of the skull, top of the neck. Oftentimes people describe it as a sensation of pressure in addition to pain. It may radiate. It may go up towards the top of the head. It may go across the temples to behind the eye. It may go down into the neck. Oftentimes it's worse with certain maneuvers, which we call Valsalva maneuvers. These are maneuvers that increase the pressure in your chest, your sort of thorax area. And these things include laughing, singing, cheering, coughing, straining, sneezing, looking up. All of these things tend to make Chiari headaches worse. And they would be less likely to make other types of headaches, like migraine headaches, trigeminal neuralgia headaches, other types of headaches could get worse with these maneuvers, but it's a little bit less likely. So this is just a way that from a patient history, you can get a sense, does this seem like it fits with at least the classic Chiari malformation? And the thing with history is each of these different diagnoses is going to have its own history, which is going to vary from person to person, but overall provides a general idea of what's going on. Physical exam is another important tool that we use for an initial evaluation. There can be some distinguishing things on physical exam which push us to consider one diagnosis more than another. One of these is the body mass index, basically the ratios of how a person's weight to how tall they are. Certain conditions are more common in elevated BMI or lower BMI. And this is something that we can measure and that we consider. Tenderness along the occipital nerves or along any nerve, what's called a Tenel's sign. If someone is extremely tender over a particular nerve, then that can suggest that that nerve is inflamed, and oftentimes these inflamed nerves can be the underlying cause. Sometimes in combination with the Chiari malformation, sometimes independent of a Chiari malformation, where it's really just the occipital neuralgia, for example, that's acting up. Joint hypermobility. This is classically like hypermobility. Ehlers-Danlos would be one example of this. And there's the Baton score, which is a physical exam where we're looking at how flexible someone is through some objective means. And depending on what your score is on the Baton score, our suspicion for an underlying hypermobility syndrome is either going to be very low, very high, or somewhere in the middle. And depending on where that is, it's going to guide what other testing we may want to do, and also what history we're asking, and how we look and measure the imaging studies. The other thing, physical exam in person, we can test physically for hypermobility by a little bit of gentle traction on the neck, by moving your head in certain ways and seeing what feels better, what feels worse. And then, of course, anytime you're going to see a neurosurgeon or a neurologist, you're going to get a thorough neurological exam, which is cranial nerve exam, strength, sensation, reflexes, abnormal movements, ability to walk, demonstrate your coordination, and other things that, because we see this day in and day out, are going to point us in a given direction. Imaging is very important. And Chiari-1 malformation is defined as 5 millimeters of the cerebellar tonsil, the bottom part of the tonsil, laying below the level of the bottom of the skull, or the foramen magnum. And I've sort of drawn a blue horizontal line across the screen at the base of the skull from the front of the foramen magnum to the back. And the little double arrowed is measuring how far that part of the cerebellum is protruding below the foramen magnum. Now, Chiari causes its symptoms by causing compression of the cerebellum and the brainstem, by obstructing fluid flow through that area, preventing fluid flow from flowing between the brain and the spinal columns and back and forth. In severe cases, it's hypothesized that this blockage of flow is what leads to syringomyelia. So it's very important to look at imaging studies. Some of the other things that we'll look at is, does someone have a syrinx? What's the difference between a syrinx, which is pathological, and a persistent central canal, which is just a remnant of when you're developing, there was just a canal within the spinal cord that has persisted as an adult. And they look different. And if you know what you're looking for, you can make a judgment about which is which. And that's something that's really important to do with imaging. Sometimes if we're worried about neck pathology, we'll get flexion extension films of the neck. If we're worried about craniocervical instability, we can look at different MRIs, bending forwards, bending backwards. We can look at different measurements on the MRI. And so we rely pretty heavily on the MRI, and it does give us a static picture of how things look, and we can measure things. Intraoperatively in surgery, I also do an ultrasound to look at a video similar to the video that you would have of your heart during an echocardiogram, or a fetal ultrasound to look at a baby in utero. You can sort of see how things are moving with heartbeats and how things look, and that's another imaging option that we utilize for surgical candidates. The importance of consultations. Nobody wants to be going around seeing a bunch of different doctors, but oftentimes what other physicians find can be very helpful. For example, if you have a neurologist and you've tried every migraine medication under the sun and none of them have gotten better, and you've had a thorough workup of the other neurological conditions, and your neurologist says, well, I think this really could be the Chiari, that is a situation which doesn't happen all the time. But in that situation, I have a lot more confidence that people are going to get better with surgery. We ophthalmologists, they can look in the eyes and they can indirectly measure the pressure in the brain, called papilledema. This presence of that causes us to put the brakes on things and work things up for increased pressure. If someone has persistent dizziness, nausea, vomiting, which is very common in Chiari, and they've seen an otolaryngologist or ENT doctor, and they've ruled out any sort of ear-based cause of the dizziness, then that's very reassuring that it's in fact coming from the Chiari. Pain specialist, did injections help? Sleep studies, do you have obstructive sleep apnea or central apnea? Central apnea is from compression of the brainstem, which you can see in severe Chiari. Cardiology, if you have issues with syncope, fainting, tachycardia, high blood pressure, has cardiology found an obvious cardiology cause, or are they kind of scratching their heads saying, this doesn't make sense to me, maybe this is coming from the brain? Um, Going around seeing all these different doctors, delay in diagnosis, which can be around 5 years for most patients, is mentally taxing. And patients can have anxiety and depression either at baseline or because of everything they're going through with a lack of diagnosis and the significance of the symptoms. And we do encourage people to see psychiatrists or psychologists, even if their primary issue is a Chiari and not the anxiety or depression. We want to kind of optimize everything and get you feeling better through all ways that we can. And so these strategies can be very helpful in combination with other things. And then physical therapy. You know, if we're worried that somebody has cervical disease in their spine, in their neck, that's causing their headaches, but they've done physical therapy, they've done injections, they've tried all these different treatment options, and their physical therapist is kind of putting their hands up, then that's a good sign that we shouldn't be sending you back to physical therapy. You've already done all that. One of the things I talk to patients about is, while 85% of patients that we say are surgical candidates are going to get better, if you're in the 15%, what are we going to say to you after surgery? Well, we're going to make recommendations to see some of these other doctors. And my personal preference is that you've already done all that, you've already tried all that, you've already ruled it out, because it makes more sense to try physical therapy first. And if it works, great, you don't go on to have surgery, than to not try it, have a surgery, and then do physical therapy after surgery, and your neck pain is better. So I try and do things up front. Then we'll talk about a few case examples where some of the things that come up is the overlap of symptoms between different conditions. Atypical presentations, meaning some of the Chiari patients that we see don't have any headaches, right? And that's not typical. So, but having broad experience treating these different conditions, and thinking in an open-minded fashion, you can put these things together even when they're not straightforward. And that's the other bullet. So craniocervical instability. This is a diagnosis which oftentimes causes a very similar presentation to Chiari. Oftentimes they can involve a degree of brainstem compression, herniation of the cerebellum. History is very important in this. And the specific things that people say that have craniocervical instability are things that people who don't have craniocervical instability wouldn't say, and most people wouldn't say. And so there's a variety of red flag things that people tell me, and the wheels start turning, and it's aha, you know, this is something that we really have to look out for based on what this person's describing. Now we get the Baton score on everyone. If the Baton score is 5 or higher, again, that's suggestive. This person's super flexible. They may have a degree of craniocervical instability. And I talk to people, it's not like you had a trauma that disconnected your ligaments and broke your bones and you're decapitated, which we do see in other aspects of neurosurgery. This is more a hypermobility syndrome, and it's more that the degree of laxity causes a lot of symptoms. And importantly, it's been shown in a lot of people that undergo Chiari decompression that don't get better, they go on after the fact to be diagnosed with craniocervical instability. So again, much better to get that diagnosis before and not go through a surgery that makes you worse. And nowadays, it's becoming more and more on people's mind than it was, say, 20 years ago. But still, not everyone is thinking about this and working it up. I'm pretty conservative with folks that have this, to not want to do an operation that's going to make them worse. And I refer them to specialists who deal with craniocervical instability, deal with craniocervical fusions, just to get an opinion out there of what some of the examples are. We get flexion extension MRIs where you're sitting up and you're bending your neck back. They get an MRI bending it forward. We can measure the different angles. There's a variety of measurements, which I list here, which are sort of technical, but these are all the different things that we're looking at. There's not clear consensus on these things, but if there's enough red flags and enough of these look like they're in the range, then I tend to err on the side of there being a degree of craniocervical instability. CSF hypotension, or spontaneous intracranial hypotension. This is a really important one. This is the one that I really get the most concerned about people not thinking about and doing a Chiari surgery and having people get significantly better. So the history is again important. Oftentimes this sort of comes on suddenly. It can come on as a result of whiplash, trauma, spinal injections, spinal surgery, certain hypermobility syndromes, sometimes no cause at all. But it's generally headaches that are worse with sitting up, and they're just these terrible, terrible headaches, similar to like a post-lumbar puncture headache. They improve with laying flat. Often they improve with caffeine. And these folks also go a long time before ultimately getting a diagnosis, because this is not a diagnosis that most people put at the forefront of their mind. We have all the patients fill out a CSF hypotension questionnaire, which gets at some of the key factors that patients with CSF hypotension also often present with. And if that score is very high, again, it raises red flags, and we sort of hone in on that. CSF hypotension is a condition where there's a leak in the spine, and it causes the brain to sag down. And the sagging down can look to many people like a Chiari, because again, the tonsil, the part of the cerebellum, is below the level of the foramen magnum. However, when you look at certain things, and this image is sort of a classic one, the pituitary gland is very plump because the pressure is low, so it's really expanding out. The venous sinuses, which are the veins, which are usually triangular, they get really big because the pressure is so low, so they're very plump. Certain structures of the brain, which are normally spaced apart, get really compressed together because the brain is being squeezed down. And if these folks go on to have posterior fossa decompression, you just create a bigger hole for the brain to slide down more, and people can do very, very poorly with that. I've seen patients where they went to someone who recommended a surgical procedure, and these were very reasonable surgeons, but the patient had CSF hypotension, and we advised her of that and referred her out to folks that sort of specialize in blood patches and finding a leak, and ultimately her symptoms got much better. She does seem to have a concomitant Chiari malformation. But things would have been bad for her had she just undergone that Chiari decompression without people sort of thinking about this alternative diagnosis. If there's tough cases where I'm not sure about it, I review it with a neuroradiologist who I trust here at the Medical Center of Aurora. And together we look at these things and come up with a plan together. Idiopathic intracranial hypertension. This used to be called pseudotumor cerebri. This is the pressure in the brain is too high all the time. The brain on MRI images looks very plump. The fluid cavities of the brain are collapsed. And sometimes this plumpness of the brain can cause the tonsils to herniate below the level of the foramen magnum, similar to a Chiari. But again, the underlying mechanism is quite different. And these folks are oftentimes not going to get better with Chiari decompression, and they're going to be high risk of developing CSF leaks, Pseudomeningoceles, requiring shunting, things like that. So this is more common in females, as same with Chiari. It's oftentimes related to being overweight or obese, and we don't have a great explanation for that, but it does, in most cases, it is related to being overweight. The symptoms are a little bit different from Chiari. The radiographic appearance is different, the imaging is different. Now we're going to send anybody who we're suspicious, either because of their symptoms or their weight or the MRI scan, to go to see an ophthalmologist to look in the eyes to look for any evidence of pressure. These folks oftentimes present with headaches and also visual disturbances. For treatment options or diagnostic options, we oftentimes get a lumbar puncture done correctly by someone who knows what they're doing to measure that pressure. And before we sign anybody up for certain treatment, we want to get a lumbar puncture to confirm the diagnosis. Treatment is difficult, right? Because it involves losing weight, which is very challenging, especially when you're not feeling great. But we refer people to nutritionists. Ultimately, we refer people to bariatric surgeons or medical weight loss, in the same way that we would refer somebody that had high blood pressure to a cardiologist. They're not gonna will themselves to get their blood pressure under control, right? And you're not gonna will yourself to lose weight. you know, it's something that we have colleagues that specialize this, and it can be helpful. And even losing, you know, 5–10% of your body weight can be enough to make the symptoms get better. Now, losing weight doesn't work for everyone. Some people have it and are quite thin. And so then there are certain medications that we can try. And so we just have to sort of keep an open mind, listen to the patient, listen to what works, what doesn't work with colleagues who specialize in the medical treatment of this, have folks follow up with ophthalmology. And if they have a Chiari malformation and they have persistent Chiari symptoms, after the IIH is under control, sometimes these patients can go on to have surgery and not have the complications affiliated with folks where it's untreated. Cervicogenic headache, this is degenerative disease of the spine. Sometimes it can be from whiplash injury or trauma, poor posture, genetics, starts in the neck, radiates up into the back of the head, same location as with a Chiari. Certain physical exam findings, testing certain range of motions of the neck causing pain are helpful. Radiographic evaluations are helpful, looking at the joints, looking at arthritis. Success with physical therapy, medications, injections are important. And so this is also very important to keep in mind because it's common. It's much more common than Chiari, and they can present very similarly. Occipital neuralgia is another thing that we think about, where it can be similar to Chiari in location, radiate up in sort of a ram's horn distribution. It can be caused by arthritis, trauma, inflammation, bad muscle spasm, or just for unknown reasons. And the treatments for this are going to be different. A Chiari decompression for occipital neuralgia is not going to end up in the patient feeling better, because those nerves are going to get stretched and irritated. So there's a lot of alternative diagnoses that we think about, that we're going to ask about, that we're going to check other specialists to see. A lot of this will show up on history, physical exam, imaging, or consultation with other docs. Again, it really just comes down to a thorough evaluation and really getting to the bottom of things. So putting it all together, I want to leave some time for questions. Many patients with Chiari-1 malformation experience delays in diagnosis, skepticism from physicians that there's something wrong with them, and comorbidities from the ongoing symptoms. You know, and it really affects their quality of life, and it affects their family. It's very significant. This oftentimes causes folks to be like, I've had it, I'm desperate, I just want something done. Finally, I know what's wrong, I want to get it fixed, let's go. Let's have surgery yesterday. However, given the fact that there's all these different diagnoses and there can be common ground between these different things, and we really want to optimize every aspect of people's life and health before we sign them up for a big surgery, I really try and encourage people to have a prudent evaluation, very thorough, by somebody who's got an open mind, who's thinking about all these other things to really land on the thing that's going to be best. Again, we don't want to do surgery in folks that aren't going to get better with surgery. Now, we don't have a crystal ball. There isn't a definitive test, blood test, imaging finding that's going to tell us 100% somebody's going to get better with surgery. We don't want to only operate on the very most severe people, because then people who could get better, you know, don't have that opportunity. The severity of the Chiari radiographically doesn't always match the severity of the symptoms. So we really want to avoid people having surgery that don't need it. At the same time, we don't want people that can have benefit from surgery. We want to make sure they're getting it. And overall, the goal is to improve folks' quality of life through one way or another. We do use Chiari symptom profile, which is an objective measure of quality of life. We get this before surgery, they have surgery, we get it after surgery. And what we found is 85% of people at 2 months and 1 year experience a dramatic improvement in their quality of life. That's not your MRI looks better, you should feel better. That's they really on a day-to-day basis are reporting that they are doing more things. And the score correlates to how people are saying. So my experience at the Colorado Chiari Institute, as I mentioned, trained under Dr. Oro. He's an important mentor. I've been doing this for 2 years now. I've seen 180 patients in the office for consultation. Over 60 of those patients have gone on to have surgery. We talked about that 85% improvement. but it's not 100%. And so we really want to make sure we're getting to the bottom of everything. Thank you. I want to thank the Bobby Jones, Chiari, and Syringomyelia Foundation for the opportunity to talk to you and for everything that they're doing with patients with Chiari and Syringomyelia to advance the field and advance patient education. I want to thank the Colorado Chiari Institute and the Medical Center of Aurora. It's really a team effort to take care of these folks. And, you know, from the anesthesiologists, the ICU doctors, the consulting docs if needed, the nurses, the physical therapists, the OR team, everybody really is keyed into, oh yeah, it's another Chiari patient, just like Dr. Oro, just like Dr. Steven. And so you're not a zebra here. We know what's going on. Nobody's going to be asking you, what's a Chiari? And I'm really grateful for the team that really helps people have good outcomes. And then lastly, I want to thank Kimberly Sexton, who's the MP that works in the practice, really dedicated, much like Dr. Oro, her whole life to this and taking care of these patients. And she's a key member of the team. And again, Dr. Oro for everything he's done for Chiari patients and for me personally. It's really all about the patients, and seeing patients get better one way or the other is great. This is just a pre and post-operative MRI of a young woman who was very severely impacted by her Chiari, and now she has her life back and is really a new person, and it's great to participate in that. And I'd like to open it up for questions. It doesn't look like I'm getting paged, so we've got some time.
Good. I know. I just found out about that. I'm going to try to get to the really good ones. So, thank you, Dr. Steven. That was great. There was a question that came in earlier. I want to ask that one first. So, what is the best way to evaluate whether symptoms may mainly be due to that unstable atlas, like so that kind of CCI issue, or is it Chiari itself? So, like, how do you really differentiate those two things in real time?
Right. No, that's a great question, and that gets at the heart of what we're trying to do in the office. I try and get an overall gestalt from all the different information. If the physical exam is not, in the history, is not suggestive of craniocervical instability or hypermobility at all, like when I apply traction, it doesn't feel better, it doesn't feel worse, they're not super flexible, they're not saying the type of history things that people with craniocervical instability say, they don't fit with the demographic, they've tried certain things that I would expect to be helpful that haven't been helpful for them. I don't get too worried about some of the radiographic measures being outside of like the bell curve of normal, right? But I do look pretty closely at it. That being said, if somebody has really bad symptoms and their MRI doesn't look that impressive, then we sort of have an honest conversation about the risk, and even if it's low, there is some risk of if you do a Chiari decompression surgery that folks can get worse if there's a component of craniocervical instability. Now we can reconstruct the muscles with a plate. We are, minimizing disruption to the muscle attachment at C2. We're really trying to prevent any sort of instability in anyone. But if there's red flags, what I've been doing is referring to a Chiari specialist that has experience with doing the occipital cervical fusion. Although I'm very honest with patients, I tell them if it was me, I wouldn't sign up for that. That it's helpful in some people, but you're really talking about limiting range of motion, which is really important. I've used people's skull to their neck when they break their neck, and they're glad they're fixed, but they complain about the lack of motion, especially as they get older. And so I err on the side of not doing the fusion or referring to someone who does. Just based on my own comfort level and my own practice. But it's really a combination of factors, and different measurements are coming out all the time, and different people are saying, oh, it's all this, oh, it's all that. And we'll just have to stay tuned for it. But I try and be honest with folks. If I'm really worried about it, then I say, look, you need to get some other opinions, and we just got to go slowly.
Yeah. Sort of to that, the different measures, there was a question, is it possible to measure on imaging whether or not a Chiari or Chiari-like symptoms are being caused by some kind of pushing from the front of the brainstem. So some sort of like anterior push. How do you see that on imaging, or is that more of a clinical?
It wouldn't be clinical. It's going to be on imaging, and it's called basilar invagination. And it basically means that your second cervical vertebrae, which is kind of shaped like a peg, that peg kind of goes and takes up space in the oval that's the foramen magnum at the base of the skull, and that can push on the brainstem from the front. And if that's mobile, then that compression can be dynamic. And we see that in certain conditions like rheumatoid arthritis, hypermobility syndrome, Ehlers-Danlos, post-traumatic, just really bad arthritis, and just congenital abnormalities of the skull base. But it would really be an imaging feature, and the imaging feature of basilar invagination would be a serious red flag to doing a Chiari decompression without doing some sort of stabilization procedure. The stabilization procedure, if you need it, then you need it, right? But I have to be really convinced to do it with my hands that you really need it.
Yeah,
but in basilar invagination with compression of the brainstem from the front that's significant, then that's a good situation where you would need it.
Yeah, absolutely. And I actually had a question. What you were talking about using with and without contrast of that MRI of the brain. So I genuinely don't know. So why do you use contrast? What does it show, I guess?
Right. So the contrast, it's really just to be thorough, and oftentimes it doesn't show things, but what it can show is in CSF hypotension, it can show the venous sinus as well. It can show if there's dural enhancement, which is due to irritation from the brain sagging down. I've had patients where they present with symptoms and they have a Chiari, but based on the MRI with contrast, we've diagnosed them with MS. And usually there's elements of the history that are suggestive of that. But if we already have that imaging done, then we can talk to them about that. Look, this confirms our suspicion. And folks with MS don't want to be having Chiari decompression operations if what they really need to do is see a neurologist and get on medications for MS. In folks that have a syrinx, contrast, I use it to make sure there isn't a tumor adjacent to the syrinx in the spinal cord. So it's also a sort of an important study in that. I've had a patient where there was a low-grade glioma in the fourth ventricle, which again didn't show up on the contrasted MRI because it was a low grade. But again, you're talking about signing people up for a big surgery, and so I think having the most information is possible. And if folks don't have allergies to gadolinium or renal disease, ultimately I think they tolerate it pretty well.
Okay. Yeah, no, I was just curious. A question came in. I'm going to shift to kind of like presentation and some symptoms. So kind of small syrinx in the lumbar area, does that cause difficulty walking or climbing stairs? What are the symptoms of maybe even a smaller syrinx in that lower area?
Yeah, so generally the spinal cord ends at the level of L1 or L2. And then below that level, it's generally the spinal nerves. So if there's a significant amount of the spinal cord itself in the lumbar spine, then that raises the possibility of a tethered cord, which is another thing that we look at. We have people do a tethered cord questionnaire, and if it can go hand in hand with Chiari, relatively rarely, but we do screen for it. People that have a lot of symptoms that fit with tethered cord, we get a lumbar MRI. There are these entities called central canal, which oftentimes are asymptomatic, and depending on the shape and the size, it can be very difficult to attribute lower extremity dysfunction to that alone. If the syrinx is quite large and loculated and irregular, and the symptoms are classic for that, then it certainly can cause those symptoms. If it's very, very small, sometimes I worry it could be a red herring, and I really would want to make sure that we were looking at everything else. That being said, anybody that has a large central canal or what appears to be a syrinx, they're going to get a thorough workup for syringomyelia, which is going to include looking at the skull base, looking at CSF flow, looking at the contrast, looking for scoliosis. All these things are gonna kind of go into that. And syrinxes can be a little bit of a mystery. And I have colleagues that ask me, "Oh, what do you think? You think this is related and or not?" And it's difficult, but I think that's why it's important to go slow with it.
We had an interesting question, and I'm sort of paraphrasing it because it was a little long. And I don't know, do you notice if there's a particular time of year that Chiari patients end up presenting at your clinic? So, for instance, patients that have dysautonomia, like POTS-like symptoms, obviously have difficulty tolerating heat. So it's possible that they come in more often during the summer. And I know a lot of patients often say that that barrel pressure from like rainstorms can make them notice symptoms more clearly, whether or not I don't know if it's affecting it. But I guess the question really is, do these types of symptoms suggest that patients might do well with a Chiari surgery or some other treatment?
Yes. So I understand the question. Honestly, the biggest thing that seems to impact when people present is really sort of lifestyle stuff related to, like, I'm out of school, or I'm on break, or it's the end of the year and I'm at my deductible and I'm looking to get things checked out, more than any other individual factor. We're here in Denver, so Mile High City. People live in the mountains, they go to the mountains, and I have patients with Chiari who note difficulty with changing elevations, with flying, with barometric pressure, and that's true. There are folks that can have like POTS or other sort of dysautonomia symptoms, which can be related to Ehlers-Danlos and other things. And these folks are would be more likely to maybe present in those times. But I don't see a very large number of those patients. And oftentimes I would only recommend a Chiari surgery in them if they had a severe Chiari, which I could attribute to the cause of their symptoms. Because folks that have some of these dysautonomias, it's more of a global issue than that can be fixed with a focal surgery. So I would go a little bit slow with that. But yes, we are well aware of those conditions and the things that make people better or worse. But in my practice, it doesn't seem that they all show up a particular time of year. It's generally more related to convenience and when they got referred and when they got diagnosed.
And you kind of talk about lifestyle. So there's a question how inflammation factors into the symptoms of conditions like IIH or Chiari. You started to talk about it. So I guess what's really the mechanism there of that inflammation causing these symptoms?
Right. Well, that's a great question, and I don't think we really know the answer for that. I mean, inflammation generally causes cytokines and things that could trigger pain, signals to go back to the brain. If there is a degree of dysfunction anywhere in the body, and you add a layer of inflammation on top of it, you can certainly make that worse. And that's the mechanism of a lot of the medications we have, like non-steroidal anti-inflammatory medications or steroids with conditions. They just sort of work by decreasing inflammation, and people can get better. Now, people with certain dietary allergies or food intolerances, if they alter their diet, that can reduce the inflammation in the body, and that can make whatever their underlying condition is feel better. I would admit that I'm not an expert on functional medicine or inflammation, but I do talk to people about that playing a role. And reducing inflammation is good for a variety of things. And so we do the wellness evaluation. We do talk about diet, and that we have seen people improve their quality of life just by addressing those things alone.
I'm going to bounce around because there are a couple of questions that I definitely want to get to just in case you do get called away.
Sure,
um,
yeah,
so, what are the treatments that exist without the need for surgery? So, do any non-surgical treatments usually work better or worse for patients with Chiari? And then what about syringomyelia, since that's kind of a different animal from time to time?
yeah. I would say there aren't any definitive treatments for Chiari or syringomyelia other than surgery. However, there are a variety of medications that can help with the symptoms of Chiari. And if you're not having the symptoms and you're having a good quality of life and doing all the things that you want to do, and you're avoiding a bigger surgery, then there isn't anything particularly dangerous about a Chiari, and we would just monitor it over time. Now, if someone has a large syrinx, that would push me more towards an operation to decompress the craniocervical junction if that's the cause of the syrinx, because as the syrinx gets bigger, you can get some irreversible neurological damage. Now, a central canal is a different story, but a legitimate syrinx, that would push me to recommend surgery, although ultimately it's always the patient's decision. We do have patients with Chiari who say like, look, I'm super happy that I learned about this and it makes sense. And no offense, but I'm not having surgery, right? So I'm going to just manage this with diet, exercise, and and my neurologist is great. They give me medications, and it doesn't make things completely better, but I can function, and that's fine. That's very reasonable. But there's not definitive medications that it would be like, you know, penicillin for an infection type of a thing.
Right. So it's really based on whatever the symptoms are, right?
Symptom management, exactly. And some of these meds are going to work in a mechanism that makes sense that they could help with Chiari. And again, sometimes there's overlap between what's Chiari, what's migraines or other sort of non-specific pain syndromes that we don't know. I mean, all pain is perceived in the brain, and so some of these medications alter the way that these signals go through or pain is processed. And no matter what the source of the pain is, some medications can help with that, even if they don't treat the quote unquote problem.
Just took some anti-inflammatories myself. So, um, sort of about this. So, this is more about syringomyelia. Does a syrinx need to disappear on the imaging after surgery for it to be considered, treated in a Chiari patient? How do you determine if that patient is truly better or if there's something else that maybe this syrinx is being caused by some other cause? How do you know if they're better? Is it okay if the syrinx is still there on follow-up imaging?
Yeah, no, that's a great question. And this is something that we see. The syrinx generally doesn't go away completely, but oftentimes it will collapse, meaning that instead of being like sort of like balloon animal shaped, right? It's just more just relaxed, sort of collapse, but you can still sort of see it's there. So if I see that the syrinx is smaller and objectively, based on what the patient's telling us and filling out in the quality of life survey, if they're better, I don't get terribly worried if there's still a little bit of syrinx there. If the syrinx is not smaller after surgery, but the patients are dramatically better, then that's something I would just keep an eye on going forward. If the syrinx isn't better and the patient's not better, sort of knock on wood, I haven't run across that particular situation, but that would prompt me to do a little bit more workup. But like I said, my whole goal is to do all of the workup and things like that before surgery so that we're not in a situation after surgery where like, yeah, we should have done that first maybe. But if it's not getting better and the patient's not getting better, I would follow it and I would consider doing something about it.
Sort of,
Oftentimes it gets better, but
yeah.
not completely better.
In that vein, I know we've had this question before, and I rarely know what to say. So if a patient has a really big searing, say it's like almost holocord, but they're totally asymptomatic, what do you as a neurosurgeon do with that image? Like, is that something that should be operated on, or what do you do in that case?
Yeah, I mean, I think it depends a little bit on if we can find the cause of a syrinx, right? So if the cause of the syrinx is blockage of flow at the craniocervical junction, and that's very obvious, then I would encourage the patient to consider a decompression. Like I said, because ultimately, somebody's in neurosurgery, there's this straw that breaks the camel's back phenomenon, where a lot of these things are going on for years and years and years and years, and then something changes, and all of a sudden, people are super symptomatic. So I think it's worth a conversation about it, and I probably would encourage someone to undergo the decompression. Now, if it's a syrinx that we don't know what the cause is, and a suboccipital decompression is not going to be helpful, and they're totally asymptomatic, I would not recommend shunting the syrinx in that particular case. In general, I try and avoid shunting syrinxes
Yeah,
because it generally doesn't work over the
right.
long term. Yeah.
Absolutely. So a question came in the chat uh, about people who maybe don't want to get contrast with that MRI. I know we were talking about that a little earlier. And then are there, a second part of the question, are there other options other than lumbar puncture, as it's invasive and it can also kind of cause a little bit of a hypotensive issue? So those are two separate questions, I think. But,
So, yeah, I mean, we just make recommendations, right? So if somebody cannot get an MRI because they have a pacemaker, which is a little bit unusual in our population, but in theory, or if they don't want to get contrast for one reason or another, then we would just get it without contrast. And there are certain other features that we could look for. And if there was something that I was really worried about that I thought contrast would really, really be helpful, then we could have sort of a one-on-one discussion of like, what's your concern about getting contrast? And, based on this and this, I think it could be helpful. If it's just an academic thing, like I just curious, then no, that's not necessarily a good reason to get it. I agree, especially if someone has a good reason to not get it. With respect to the lumbar puncture, it depends on what you're looking for, right? Like, so if somebody has CSF hypotension and it's obvious, then no, I wouldn't confirm it with a lumbar puncture because I'm already convinced that they have it. Now, sometimes in the course of working up CSF hypotension, people will get a myelogram. And, to do that, you're doing a lumbar puncture anyway, so you could measure it while you're doing it. For IIH, if they were worried about the pressure being too high, then before somebody goes on medications, I would want to have some objective evidence of either papilledema on eye exam or a lumbar puncture. Because my personal practice is I don't just say that the pressure is high or low or maybe both at the same time without some sort of objective evidence, because I just don't think that that's how I like to practice. But again, we don't force anybody to get lumbar punctures, and it's always a little bit of a choice. Sometimes we do epidural blood patches in folks that we suspect have CSF hypotension, and sometimes if you have papilledema on exam and everything else seems to point towards a diagnosis of IAH, then we just treat with medications and counsel on weight loss. But yeah, I'm pretty conservative. So if somebody has a good reason for not wanting to do something, we'll try and work around it.
and you kind of started touching on this other question. What's the actual treatment for CSF leak and hypotension? Is it surgical? Is it medical? Is it a bit of both?
Yeah, I mean, that's a good question. Generally, it consists of either one of two things: finding the leak and fixing the leak. And that can be done with a blood patch or glue or with the surgery, or fixing the leak without finding it, which can be like non-specific epidural blood patches, which oftentimes can be helpful. But it's tricky to treat. It's tricky to find the leak. it sort of depends on where the leak is. If I suspect a skull-based leak, then I would defer to neuroradiology or ENT colleague to look for that. But again, in my practice, there has to be objective evidence of an actual leak, either through imaging studies or beta 2 transferrin or obvious MRI imaging. I don't make the diagnosis without sort of what I would consider to be definitive evidence, even if the symptoms seem like they fit with it.
Yeah. So actually, you brought this up in your slides. You were listing all of the different specialties that you really prefer people to kind of see beforehand, if you can, so you can get their reports. And I had a question that I thought of, so I don't know if it's a silly question, but are any of the reports that they would get to you, are those symptoms potentially transient? So should the patients go back to those physicians, particularly when they're having symptoms, or is it something that's just going to be objective no matter whether or not they're having specific symptoms at the time? I hope that made sense.
No, yeah, that's a good question. What I would say is we're not sending people to cardiology unless they have, cardiology problems, right? So oftentimes what happens is people have been undiagnosed and they have a variety of symptoms, and the dizziness lands them in an ENT office. The heart palpitations, high blood pressure that's unexplained, things like that end them up in the cardiologist's office wearing Holter monitors. And or they have really bad apnea and they end up getting a sleep study. And so usually it's more of the fact that somebody already went to that office, had that visit, paid for that visit, paid for that test. The information is out there, and we're just trying to get it so that we can help make the most informed judgment. Now, there are cases that we're going to see something that other people haven't seen, and we're going to refer someone to ophthalmology or one of these other specialists, rheumatology, based on something that we see. But generally speaking, these specialists, the patient's already seen them in the past in part of the journey of getting to the bottom of what's going on.
Perfect. Thank you. And there's a question that came in ahead, talking more about the chronic pain syndrome. So how common is that in Chiari patients? Sometimes it's called somatization. I can't speak, but you know what I mean. And is that something that is you try to treat medically first? I know that that's kind of a rough symptom if it appears.
Yeah, there is somatization disorder is, and this may not be exactly what the question is getting at, but it's basically symptoms felt in the body that are originating in the brain. I mean, or like it's in your head. And like I said earlier, to some degree, all of these experiences and feelings, and like if a car runs over your foot, you're going to feel that in your head, right? And you're going to feel that pain because that's where you feel pain, is in your head. And the whole like it's in your head, which is generally like a way that people say like, I don't know what's wrong with you, it must be you, it's not that I can't figure it out, you have somatization disorder, or you've undergone such terrible events and stressors that your body is interpreting those events through physical pain in the body. And pain is poorly understood, but for people that I feel like there is a significant component of somatization or trauma or pain that's very non-specific that I can't be confident is coming only from the Chiari, then I would sort of send those people to experts in those areas. And that can be sometimes it's psychiatry, sometimes it's pain management, sometimes it's rheumatology if I think it's a diagnosis more like a chronic fatigue syndrome or fibromyalgia. All of these somewhat unsatisfying diagnoses that we don't know exactly what the cause is. One day we probably will, and then we'll look back and say, remember when we didn't know what that was, ha ha ha. But it's tough for patients who are going through it, and it's a multidisciplinary approach. if I'm thinking it's an underlying somatization disorder or a different type of chronic pain disorder, or there's something else going on that's more important than the Chiari and affecting quality of life more, I would be reluctant to recommend going forward with a big surgery.
Yeah. Sort of in that vein, there was a question about, is there a use for regenerative medicine or stem cell therapy in things like Chiari or sphingomyelia?
Yeah, I think the evidence is in the early phases, and I have some colleagues that have told me they've had good success with those therapies in craniocervical instability and in some other issues at the craniocervical junction. I wouldn't necessarily recommend it as a treatment for Chiari. It's also an option that's only going to sort of be there for folks that are going to be able to pay large sums of money out of pocket. And so anything with that, I just say, look, there's not great evidence out there that this is helpful. Some people find it helpful. It's expensive, and so you have to sort of weigh the pros and cons of whether or not you think it's good for you. I mean, I think it remains to be seen. I see a lot of people that get those treatments for a variety of issues up and down the spine and really swear by them. And for them, it sort of helps them avoid surgery and here people are pretty active and doing the things they want to do. And so generally, I sort of view that as a win. But I also don't tell people that that's their only option or that they should spend all of their money on something that we just don't know if it's going to be helpful specifically for them.
There was a question here. So if someone's had surgery, it's been a couple of years, the operation created space and there's flow at the craniocervical junction. Oh my God. But there's still some pain and balance issues. So what should someone who's still experiencing those kind of dubious symptoms, even several years later, we're assuming it's probably not from the Chiari anymore. What should that patient be doing? What specialist should they be seeing specifically?
That's a good question. I think if a lot of the symptoms get better, but not all of the symptoms get better, then it's usually that those symptoms were unrelated to the Chiari, or maybe are related to the Chiari, but just didn't get better with the Chiari being fixed. And that can be challenging for people. Generally, what I recommend is, an evaluation to make sure that everything's open, that everything looks good. There isn't something obvious that can be fixed. Oftentimes there isn't those things. And then we oftentimes refer people to neurology for medical management. If someone has predominantly a pain component, I'd probably evaluate them for craniocervical instability or get them to see someone who specializes in pain. And it sort of depends on what the primary symptoms are. Neurology is a really good place to start. And we do get requests for revision people. Sometimes we'll review those images and say, look, it could be this, it could be that, let's bring them in and see them. Sometimes they've had a great workup and everything looks really open, and I don't think there's anything surgically or Chiari related that I can offer. And we're just honest with those people and say, look, you may be better served going to see this doc or that doc based on your symptoms.
Yeah.
Unfortunately, it does happen, and it's obviously frustrating. But I worry that it's just something that was going on that's unrelated to the Chiari.
Yeah, no, it's true. I want to end with just how can people get in touch with you? Are you accepting new patients? Are you accepting new patients out of state? I know that's another thing that's kind of off. So I guess how can people get in touch with you and see you? Do you also see children and adults or just adults?
We generally just see adults. For folks that are going to be 14 and younger. I think those people are generally best served in a pediatric center, and there's tons of great pediatric neurosurgeons throughout the country. I mean, I trained at CHOP in Philadelphia. There's literally places all over, and tons of folks that really only do pediatric Chiari. And so those folks generally we don't see. Um, we are taking new patients. We take patients from in-state, from out-of-state. Um, some of our visits we can do virtually, if people are checking in, following up. But generally, the initial visit, because the physical exam is so important, we do bring them out for that. And if you look at the website, Colorado Chiari Institute, then that has information. We have an app that people can download on iTunes or wherever they get their apps, that can have some information for how to send in information and reach out to us. But we are accepting new patients, and we welcome patients from sort of near and far. And we do ask for certain things to be submitted so that we can have a productive visit, so that you're getting the most out of your time and money. And Kimberly helps with getting all that set up.